evening, everybody, and welcome to another London lecture in this series, Madness and Mental Health, brought to you by the Royal Institute of Philosophy. It's a great pleasure to have with us this evening Professor Mona Gupta. Mona is a psychiatrist at the Centre Hospitalier of Montreal University in Quebec, where she also holds an academic post in the psychiatry department. And she's well known for her research both in psychiatry and in bioethics. In addition to numerous papers, her monograph, Is Evidence-Based Psychiatry Ethical?, was published by OUP in 2014, and she's advised the Canadian government on medical assistance in dying. Her paper this evening is entitled Understanding Suicide and Assisted Dying for Persons with Mental Disorders. Mona, over to you.
Thanks very much, Edward, for the introduction, and to the Institute for the kind invitation to join you here this evening. So I wore the wrong outfit, and I can't attach this anywhere, and I have to either hold it in my hand or put it here, so I'm counting on you in case I lean forward to the water to remind me to pick it up. But I'm going to put it down now in hopes that I don't forget about it. I'm particularly in admiration of the mandate of the Institute to bring philosophy to public audience, to have the opportunity to engage, to use philosophy to engage in a range of subjects of public interest. And I say that because I myself am not a philosopher, as you've heard, but I think that this is a topic where philosophical thinking and the tools of philosophy can actually help us to make some progress in better understanding some of the knots in this particular topic. So on that, I will go ahead. I will say that not only philosophy, but other fields as well are required to think through some of the complexities of this topic. And so this work I can't claim the credit for entirely myself. I want to just acknowledge my collaborators, Samuel Blouin, who is a sociologist, Jocelyn Downey, who is a legal scholar, Amélie Gilbeault, who is a psychiatry colleague, and David Wright, who is a historian of medicine and psychiatry, and who is right there. David, if you want to have a go at me, if you could please wait until the Q&A. So what I'm going to do in my presentation this evening is kind of walk through how I understand the question or problem of suicide and its relationship to assisted dying. And so I'm going to start with the background and the legislative context from Canada, not because I particularly want to dwell on the details of that legislative framework, but merely to show you that that question, what is the relationship between suicide and assisted dying, emerges from a certain context. And if the context is different, the framing of the question might be different. So I think the question emerges. It's not unique to Canada by any means, but I think the way in which the question is asked has very much been born from the origins of the legislative framework that we have in this country, in that country. And even though I know you're having a different conversation about assisted dying here, I think that these questions are nevertheless relevant to the conversation in general. I'm then going to try to explain what I think the problem is exactly, which is not simple to do. As Anissa, the organizer, will attest, I have been fiddling with the slides until not long before this presentation, trying to get clear on how to express it. Then I'm going to try to actually address the question of the presentation. What is this relationship between assisted dying and suicide? How has it been addressed in clinical research? And that's where I think philosophy will help us. When we turn to clinical practice and we ask ourselves how these concepts are used in clinical practice, there we might be able to shed some light on the nature of this particular relationship. So you may know that Canada permitted assisted dying for the first time in 2016. I'm going to make one very brief parenthetical statement here about Quebec, not because it's not important, but because it will add even more confusion to the presentation if I talk about the parallel structure that exists in Quebec. But in fact, a healthcare law permitting assisted dying was adopted in Quebec and came into force in 2015. So that's all I'm going to say about Quebec, and I'm happy to talk about it more in the Q&A if there are persons who are interested in what's going on in Quebec in particular. So let's just say, for the sake of the rest of the presentation, that assisted dying was first permitted in Canada in 2016, following a decision in the Supreme Court of Canada known as Carter. And in that decision, a woman an elderly woman with a chronic pain condition, essentially, had made the argument that an absolute ban on healthcare providers, in her case physicians, providing assistance to a competent adult who makes a voluntary request and who has a grievous and irremediable medical condition was a violation of the Charter of Rights and Freedoms of Canada. And she was successful in her case. She was joined by another plaintiff named Taylor. They were successful in their case. And with that decision, when that decision took effect, those sections of the Criminal Code of Canada that prohibited assisted dying or made it a criminal offense were not valid in those circumstances. And the government of Canada chose to then bring into force a law that would give some structure to the practice. They didn't have to do that. The court decision was enough, but they chose to do that. And that law came into force in June of 2016, an act modifying the criminal code and other related acts. And just so that people know, this law allows both provider-administered assistance, what in Europe I believe is called euthanasia, and self-administered assistance, what is called assisted suicide. Already the beginning of the problem, I think, is foreshadowed. So just so that we're all on the same page, the eligibility criteria at the time that this law came into force were as follows. There were two administrative criteria. Essentially, a person needed to be resident in Canada in order to avoid the problem of people coming from other countries to access an assisted death. They had to have achieved the age of majority. They had to have a grievous and irremediable medical condition. I'll say more about that in a moment. They had to make a voluntary request, and they had to be able to give informed consent to receive an assisted death. So I think you can see right away that the meat here is what exactly is a grievous and irremediable medical condition. And this is what the government of Canada had to say about that. Grievous and irremediable medical condition as an expression is articulated in the court's decision in Carter, but they don't actually say what they mean by that. So the government decided to go out on a limb and give it this definition, that it is a serious and incurable illness, disease, or disability, that the person is in an advanced state of irreversible decline in capability, that the illness, disease, or disability, or the state of decline, or both, causes the person enduring physical and psychological suffering that is intolerable to them, and that cannot be relieved under conditions that they consider acceptable. And finally, that their natural death has become reasonably foreseeable. Now, this is legal language, and there is actually a legitimate legal debate on what this expression means exactly. But again, just to make things not too complicated for the purposes of this conversation, let's take this to mean an end-of-life requirement, end-of-life terminal illness type requirement. So right away, in the beginning, in this legislation, in the preamble, the federal government evokes the notion of suicide, whereas vulnerable persons must be protected from being induced in moments of weakness to end their lives. Whereas suicide is a significant public health issue that can have lasting and harmful effects on individuals, families, and communities. But they don't actually make a link between suicide and assisted dying, the law that's just coming into force. They just say this in the preamble. So the reader infers there's some relationship here, but we're not told exactly what it is. So at this point in the debate, going back in time in Canada 7 years ago, the problem is something like this. It's generally agreed that society should prevent suicide. If assisted dying is suicide, then we should prevent it. And if it's not suicide, then we could allow it. We don't have to allow it, but we could allow it. But the law has just come into force. So does that mean the legislator has already decided that assisted dying is not suicide? And if they've decided that, then what's all this business in the preamble? And we don't know, actually. We don't know the answer to the question, and we don't know on what grounds assisted dying, the legislator has decided assisted dying is not suicide. So I mentioned to you that the words grievous and irremediable medical condition appear in the Carter decision, but they're never defined, and it was the government who chose to define them. And what was important about that remark is that the court made no comment about the need for the person's death to be proximate in time. It was the government that inserted this requirement that a person's death be naturally foreseeable that evoked the idea of end of life or terminal illness, or death had to be coming soon. And not moments after the ink had dried on the law, but that requirement was challenged in court by two individuals, Truchon and Gladu, and the decision was made some 3 years later. They were two individuals with physical disabilities who were, according to their physicians, eligible to receive assisted dying, apart from the fact that their natural deaths were not reasonably foreseeable. Truchon was a man in his 50s, Gladu a woman in her 70s. Now, Canada argues here that outside the end of life, assisted dying is the same thing as suicide. So they say this is going to disproportionately affect people with mental disorders, okay? If we remove this end-of-life or terminal illness requirement, because that's what Truchon and Gladu were challenging. If we remove this, we are allowing suicide, and this is going to be particularly a problem for people with mental disorders. But in the end, Truchon and Gladu won their case. And in the decision, the judge said, she accepted, that suicide and assisted dying are two separate phenomena that belong to two different realities. Okay, so now we have to try to figure out what exactly is the problem in order to come to grips with it. So I think the first question to ask is, what is suicide exactly? And it turns out to be an extremely difficult thing to define. So I'm not going to do that myself. I'm just going to show you the definitions that are used by the organisms responsible for collecting data on the question. So in the UK, suicide is defined as a death in which the underlying cause was intentional self-harm. Statistics Canada uses a similar definition. Suicide is the intentional action of ending one's life. And sometimes I'll use the word suicidality, which is something we often say in clinical practice, which refers to all of the suicide-related things around completed suicide, ideas, plans, attempts on the road to completing suicide. Okay, so now let's go back and try to reformulate the problem. Suicide is the intentional action of ending one's life. Society should prevent suicide. So if assisted dying is suicide, then we should prevent it. If it's not suicide, then we could allow it. But we've already allowed it. So what we've already acknowledged is that sometimes the intentional action of ending your life is not suicide. So these definitions that we're using, maybe they don't apply all the time, or maybe we've carved out an exception, and if so, why have we done that? Some people will argue, as Canada did in Truchon, that an assisted death for someone at the end of life is not suicide. Why? Because their death is inevitable. All that's being changed is the timing of the death. So I ask you, is this end-of-life distinction valid? I don't think it is, and here's why. First of all, suicidality exists across the lifespan. If an elderly person, let's say somebody who has exceeded the natural lifespan of a human being, somebody who's 90, somebody who's 100, intentionally ends their life, okay, undertakes an action to intentionally end their life, which is the definition of suicide, we still call this a suicide. And for example, in Canada, this is not the case in the UK, but in Canada, the second greatest peak of completed suicide is among men over 80. So there's no dispute amongst the statisticians that these are suicides. They're not saying, well, geez, they're kind of close to death, so maybe we don't call it suicide. It's suicide. We also know that people with certain types of cancers, particularly those with very poor prognoses, in other words, they are reaching the end of life, natural death is reasonably foreseeable, are at higher risk of ending their lives than those without. We call that suicide as well. So it's not the proximity to death which changes whether we refer to an action as suicide or not, despite Canada's argument to the contrary. Instead, I think what's going on is that assisted dying at the end of life is implicitly accepted as rationally chosen and understandable by others. So now maybe we are in the territory of something that's a suicide because it is in fact an intentional action to end one's life, but it's rational. So now we're evoking the idea that actually maybe rationality has got something to do with these two concepts, rationality or irrationality. So I said at the beginning that it was important for you to know the legislative context in Canada in order to be able to understand the problem. Because as you saw, there was an understanding that these two things are somehow related, and a wish on the government's part to distinguish them. And from this desire, I think, was born an empirical question. What is the difference between suicide and assisted dying? And from there, plenty of academic activity setting about to try to answer that empirical question. So essentially, what clinical researchers have been trying to do is classifying actions or people as suicidal or not suicidal using some kind of observable criteria. So they identify characteristics of persons with mental disorders who are considered suicidal and characteristics of people with mental disorders or other disorders who request assistance in dying. And the idea is, well, if the two groups share characteristics, common observable characteristics, it's assumed that assisted dying and suicide are the same thing. And if they have different characteristics, the opposite is true. And here are some of the variables that researchers have tried to study in order to make the case that these are either the same phenomena or a different phenomenon. So they've looked at state of mind. What is the state of mind of the person who completes suicide or attempts suicide versus the state of mind of someone who makes a request for assisted dying? And some want to argue that, well, the person who makes a request for assisted dying is calm, rational, the decision or the request has been well considered, whereas the person who is attempting suicide is in a state that is perturbed. They're not thinking clearly. They haven't thought about what they are doing. But in fact, empirically, that turns out not to be true. Yes, there are people who complete suicide who are perturbed, but there are also people who complete suicide who are serene, and who have thought about it a lot and who have been planning it for quite some time. So we can't distinguish on the basis of state of mind. Researchers have also looked at the question of reasons. Perhaps the reasons that motivate someone to request an assisted death are different than the reasons that lead someone to commit suicide. But again, this turns out not to be true. At least it's not a distinguishing characteristic, in the sense that people who seek assisted death will typically talk about needing relief from suffering, and that death is the only thing that's going to give them that, wanting to have dignity, wanting to have quality of life. And people who complete suicide, for example, either in clinical notes that we might have and that we can look at after the fact, or in their own notes that they write, talk about wanting relief from suffering, that death is the only solution, that it is the only way to retain dignity or autonomy, or the last things that they have left. So this turns out not to be a useful distinguishing quality. And again, sure, it might be true in some people that their reasons are incomprehensible, but unfortunately for others, it seems very similar to people who request assisted dying. Nature of the act. So we've tried to look at completed suicides, and people have said, well, these are certainly impulsive, they are violent, they are characterized by sort of chaotic circumstances, where assisted dying is calm and it's done in an orderly manner, and the people involved feel good about what's happening, feel positive about what's happening. But in fact, that also is not the case. Suicides can also be serene. They can also involve people being at peace and coming to terms with their decisions. So we can't distinguish them that way. And finally, there's the question of the impact on others. What is the impact of suicide on others versus assisted death? And here I would say we might be able to point to differences, although even that can be questioned, but these are contingent differences. Suicide in our society it's not a crime, but it is not something that you can involve anyone else in. So it is, by its nature, something that's done alone, often using violent means because that's what's available to a person. And so naturally, the impact on others, you would expect it to be different compared to something that is planned, that is discussed openly, where perhaps loved ones or family members have been involved in the process of making a decision. So it turns out that the empirical question, what is the difference between suicide and assisted dying, which is born in a context where making this distinction is prima facie quite important to do, is not going to be answered that way. So there's no characteristics that are specific to one group, nor are there a sufficient number of common characteristics that apply to both groups. So clinical research does not offer clear conclusions as to whether the terms suicide and assisted dying refer to distinct empirical phenomenon, and if they do, how we can distinguish them. So as a clinician, I think to myself, don't we have to do this every day? In our clinical work, don't we sometimes have people who we say are suicidal and others who we say aren't suicidal? And how do we come to that conclusion? Can this way of thinking shed some light on the relationship between these two concepts? So in clinical practice, we consider certain actions suicidal and others are not, because it turns out that requesting an assisted death is not the only kind of clinical situation where a person makes a decision or undertakes an action that leads to death. So I'm going to call these high-stakes decisions just to make it short, but I'm talking about situations where someone wants to refuse a treatment that's life-sustaining, such as ongoing dialysis, or they don't want a treatment that could be life-saving, like chemotherapy for certain kinds of cancers, transplantation for certain kinds of end-stage organ disease. So in these high-stakes decisions or actions, the person wants to do something and they're going to die as a result. So if we think back to the definition of suicide, an intentional action that brings about one's death, this seems to fall into that category. I sort of think about my own practice, and I work in liaison psychiatry, which is the consultation to medical and surgical units. So it's the psychiatric care of the medically ill. And I also work in the emergency room. So you'll see that's why all my examples come from these two contexts, because that's where I see people most often. So I started thinking to myself, in these other kinds of high-stakes situations, do we call these decisions or actions suicidal? And do we try to prevent people from making these decisions or undertaking these actions the way we classically conceive of suicide prevention? And I'll just make a little parenthetical statement here by way of a hint that both in Canada and in the UK, people who have what's called decision-making capacity, a legal concept, including those with mental disorders, are entitled to make high-stakes decisions, even if it leads to their death. So what options do clinicians have in the face of potentially life-ending decisions? Well, the person who is, to use a kind of tired example, but hopefully makes the point, is connected to a ventilator and is dependent on the ventilator to survive, who has made a decision that they no longer wish to continue with life-sustaining treatment. The physician is actually not only will, but is required to facilitate the person's decision by discontinuing the unwanted intervention. Sometimes we're neutral about people's decisions. We don't want to encourage them to do it, but we aren't going to stop them. We try to support their own decision-making, providing information, and so on. And I would say that sometimes that shades into persuading people not to do things if we have some reason to believe that they might, it's not well thought out, or it might be something they regret, and so on. And then in a certain small number of circumstances, clinicians are legally empowered by the state to forcibly prevent people from making certain kinds of decisions. And that's usually done through legal mechanisms, whether those are treatment orders, through court orders, et cetera. So what I'm going to do now is I'm going to show you a short series of cases. They're real cases, but appropriately anonymized for tonight. Very short little vignettes of people that I have met. And I'm going to ask two questions of these cases. One, what do clinicians do? How do they respond to these situations? Do they, from our previous list, do they facilitate the decision? Do they remain neutral in the face of the decision? Or do they forcibly prevent the person from making a decision? And second question is, if a death were to result from the decision, would the clinician refer to that death as a suicide or not? And let's see what asking these questions about these cases, if it can help shed some light on what we're trying to understand this evening. So this is a 28-year-old man. He has persistent beliefs about an evil force in the world. He's brought to the emergency room by his family after he shared with them the good news that the evil force will disappear once he dies. And he has a realistic plan to end his life. So in this case, we engaged in forcible prevention of his wish to act on these beliefs. And if he had died as a result of this plan, we would have called this a suicide. Here's a 68-year-old woman with progressive interstitial lung disease. For those of you who aren't familiar with it, it just essentially your lungs fibrose and it becomes more and more difficult to breathe. She is a candidate for a lung transplant, which could extend her life to her natural lifespan, so into her mid-80s, but she refuses a transplant. So in the face of a decision like this, we were neutral about it. We weren't trying to talk her into having a transplant, because that's quite a big decision, or talk her out of it, but wanted to ensure that she understood exactly what was involved, both if she had it and if she didn't. And if she had died as a result of not being transplanted, we would not have called this a suicide. Here's a 36-year-old man. He was sexually assaulted a few days ago. He comes to the emergency room with ideas of harming himself. But after meeting the emergency room staff, he does not want to stay in the hospital. So they're trying to encourage him to stay, to get services and supports in the hospital. So I would say this is where we're leaning more into the persuasion side, saying, you know, we can help you, we can do things for you, but he doesn't want to stay, he wants to go home, he's willing to come back as an outpatient. Fine. Nevertheless, if this young fellow leaves the hospital and engages in an intentional action to bring about the end of his life, we would call that a suicide. This is a 78-year-old man with end-stage congestive heart failure. He's he requested and was assessed as eligible for an assisted death. He's found in his hospital room 2 days prior to the date of the assisted death, somnolent, surrounded by empty pill bottles. So what we would do in this situation is, I say forcible prevention, but it doesn't quite work in the example, but we would ensure that he could not act. So we would engage in surveillance, we would try to revive him, and if he died from this action, we would call this suicide, unless there was some other explanation, like he meant to take vitamins and instead took a whole bunch of pills that were lethal. Here is a 55-year-old woman with advanced ALS, also called Lou Gehrig's disease, and she asks about whether she can have an assisted death. So in this case, we would facilitate her decision-making, meaning that we would help her to make the request. There's kind of an administrative process in Canada. You have to fill out some papers, and then you meet with 2 different physicians or nurse practitioners to make your request and be assessed. And if she were considered eligible and had an assisted death, we would not call that a suicide. And if she was following along with the process, we would not refer to her as being suicidal. And here's the last case, a 48-year-old woman with a long psychiatric history and 2 past suicide attempts. She has a recent diagnosis of a terminal cancer. She refuses treatment for the cancer, and she requests an assisted death. So here I think we would be neutral about it, again, helping her to be informed and follow the process according to her wishes. And I don't know whether when she dies, I would call this a suicide or not. I'm not sure. I'm interested to know what you think. So I show you these cases in order to illustrate that treatment refusal, treatment stoppage, and suicide, the way we typically talk about it, are all intentional acts to end one's life. But as a society, we allow certain intentional life-ending actions on moral grounds, like the lady who doesn't want to have a transplant, for example, because we value self-determination. Clinicians do not call deaths resulting from these actions suicide, whether or not the person has a mental disorder. If the action is not self-determined, so let's say the person lacks decision-making capacity, they're cognitively impaired, or they're psychotic, or they're intoxicated, we don't allow people to make decisions that will intentionally bring about the end of their life, but we also do not call this suicide prevention. In society, kind of extrapolating from the clinical world, calling certain actions to end one's life assisted dying and others suicide is a discursive choice based on moral reasons, not empirical differences. That was the point of showing you the case studies, that the empirical research has not shown us anything about how we can distinguish these two groups, but it's clear that we do distinguish between people who we call suicidal or whose deaths we call a suicide and other kinds of deaths and other kinds of choices. And what I would argue is that we are making these categorizations, if you will, on normative grounds. And of course, we could, I'm confident about the argument, I guess I would say, because we could choose otherwise. And Switzerland offers a useful example. So the Swiss assisted suicide regime is the oldest assisted dying regime in the world, the oldest official one. And in Switzerland, there are two practices. There is suicide, as we traditionally understand it, and there is assisted suicide. So they use the same language to describe both kinds of intentional actions to end one's life. One is regulated in the way that the Swiss run their regime for assisted suicide, and the other is suicide as it is typically understood here and in Canada, with all of the usual suicide prevention activities, campaigns, imperatives, etc. So there may be political reasons why we want to use different terms to describe different kinds of actions that bring about one's death. And I'm not going to take a position on those reasons. I'm more interested in trying to understand the concepts that underlie these terms. And what I've been trying to argue for you is that, in fact, it's the same concept. It's intentionally bringing about one's death, and that in some cases, as a society, we allow it, and in other cases, we do not. So, in conclusion, what I hope I've persuaded you of is that suicide is not simply a descriptive term. A person takes an intentional action to bring about their death. The way we use it in ordinary language, it includes a normative component. Embedded within the word suicide is a judgment that this kind of intentional action to end one's life is negative and it should be prevented. Asking, as we still do in the Canadian assisted dying debate, if we can distinguish assisted dying from suicide gets the question wrong. The real question is, in what circumstances is it morally acceptable for persons with mental disorders? And in fact, you can ask that question more broadly. In what circumstances is it morally acceptable for persons? I think that resonates better with the conversation you're having here, to intentionally end their lives.
Okay, thank you. My name is Nicholas, and I unfortunately had a mental illness in 1990, and my great-grandfather fought in the 20s during the First World War in Flanders, Belgium, and he died on the night before my 7th birthday. While at home, when I was discharged from the hospital, you'll think you're so clever, telling people to have assisted dying. Perhaps you can explain to me why I had near-death experience of seeing my great-grandfather in heaven and my psychiatrist in hell, and in the dream, or it felt like a dream, before I woke up that morning, they're pointing to each other so much that I became frustrated and came down a chute back to the psychiatrist in hell, and I woke up thinking, what the hell had happened? And I was 20 when that happened, and I'm now 53.
So I just want to make sure that I understood the question correctly, or the comment. Are you saying that you had a dream when you were much younger that you ought to complete suicide?
No. I had a dream. I saw my great-grandfather in heaven and my psychiatrist in hell. And when in the near-death experience, they're pointing to each other so much that I came down the chute and I woke up that morning thinking that heaven can wait for me. Okay,
so again, just correct me if I'm wrong. So you had the dream. Your great-grandfather was in heaven. Your psychiatrist was in hell. Oh dear. And you, in the dream, you...
They're pointing to each other. They're sending me up to heaven and back to hell. And they're doing it so much that I came frustrated in the dream and came down the chute. And I woke up and it made me realize that heaven can wait for me, and I started doing my own things in life. And everyone else, they can walk into heaven by having assisted dying or not wanting their physical health.
So when you woke up from the dream, you realized that it was not your time.
It's not my time to go yet.
Right.
And I've been trying to ask Mr. Swinton to explain to me why that happened, and they had no idea. So that's one that if you know, if you could answer my question.
Okay. So, I mean, if I understood the gist of it, you woke up, you realized it wasn't your time, and many years later, here you are, and I hope that the intervening years have been satisfactory. Yeah? So, I mean, I think what you're illustrating is that a request for assisted dying, I mean, I'm not here necessarily to defend that, but a request for assisted dying is something that should be voluntary.
It should be allowed after what the Nazis did to people with physical and mental health conditions during the Holocaust at Auschwitz.
Are you asking me, do I agree with involuntarily euthanizing people?
Well, if you agree that everyone should have it instead of enjoying life.
Well, I certainly believe that any regime for assisted dying should require that people make the requests themselves, that it should not be coerced, that it should be voluntary, and that they have decision-making capacity to proceed. I think you're raising an interesting question about how long it should take to establish that somebody fulfills those criteria before you can go ahead. And I think that's an open question. So for example, the Euthanasia Center for Expertise in the Netherlands that hears about 80% of the requests for assisted dying by people with psychiatric conditions in that country is now taking about 10 months to assess a request. Part of that is due to the fact that there are more requests than they could manage, but part of it is due to the fact that it takes time to establish whether somebody truly is making a voluntary choice, and the more complicated a situation it is, the longer it takes.
Thank you.
Thank you.
Hello. My question is, the law in Canada changed 7 years ago. In the intervening 7 years, what has changed in Canada in both society and also in politics around the moral acceptance of ending one's life? Have the, winds changed in some way? What are people sort of saying in Canada?
Yeah, that's a great question, and I'm probably not going to give a very satisfactory answer in the sense that I think in a way you're kind of pointing back to the fundamental problem. I don't think anybody's views about preventing suicide have changed, whatever that is, but I think people's views about having an assisted death under certain kinds of circumstances prescribed in law have changed. And I think precisely the fight is sometimes those things that we think are acceptable actually in the category that are not acceptable and vice versa. So right now, the law actually changed in 2021 following the case that I showed you of Truchon and Gladu. The requirement that people's natural deaths be reasonably foreseeable was removed because they were successful in their case. And the government introduced at that time an exclusion, a blanket exclusion for all people with mental disorders. They committed, it was a temporary exclusion, it was meant to expire in March of this year, and they extended it again until March of next year. So I think the political conversation is focused right now on the question I left you with at the end, which is, are there ever any circumstances when it is morally acceptable for a person with a mental disorder to end their life? And there are people that say, yes, there are, similar to those people with other kinds of conditions, and then there are others who say, no, it isn't, because it's always suicide. So hence, I think the need to ask ourselves, what do we mean when we say it's suicide?
Yeah, I was just to follow on from that, whether you could say a little bit more about the way in which one would go about establishing whether somebody with a psychiatric history, would be entitled to access assisted dying. Because I was thinking that in a way, it would have to be somebody who is certainly not in their younger years, because presumably there's always hope for a condition to be healed or helped with medication, therapy, whatever. But if somebody is experiencing repeated recurrence and is maybe, experiencing that from their early 20s into their 50s and has had this experience, would there then be a case, in some cases, based on your experience, to say, well, if somebody then says, I don't want to go through this cycle of distress for the next 20 or 30 years, that the psychiatrist could be relatively confident in agreeing that there is no hope? I guess what I'm asking is, with a psychiatric situation rather than a cancer perhaps, can we ever be sure that there's no hope? And what would that mean, for a psychiatrist to feel relatively confident to support that?
Are you referring to people with mental disorders who don't have any other kind of physical condition, or people like my case 6, the lady who has a mental disorder and a physical condition?
No, I was thinking about people who don't have any other health condition.
Right. So thank you. You have aptly summarized the precise debate that's going on in Canada right now. But you're right also that it does follow very well from the preceding question, in the sense that in 2021, when the Canadian law changed, the end-of-life requirement, again, just calling it that for the sake of tonight's presentation, was removed. So the people who were potentially eligible from that point on, yes, were people that had terminal conditions, but also people who had all kinds of other chronic conditions, severe neurological conditions, severe gastrointestinal conditions, et cetera. So to come back to your question, I think the answer I would give you, it's not allowed right now because there's this legislative exclusion, but the answer I would give you is, I would turn to what my colleagues are doing in other fields when they have patients with severe chronic conditions who are coming to them and saying, I want to find out more about this. I wonder if it's for me. So they're doing exactly what you suggested, I think, looking at the duration of the condition, the severity of the condition, the person's symptom profile, how long has it gone on, how well has it been treated in the past, how well can they get in between, or do they ever get well? Right? And then, of course, the most important part is the person's experience themselves, right? What is meaning and quality of life for that person, which is not the only determining factor, but has got to be central.
So my question was about, how do you determine somebody's capacity to make this sort of decision? What are the criteria? Because, as you've suggested, it's not a simplistic, if this person has a mental health issue, they are therefore not capable of making a decision. So how do you determine that?
So this question will answer it differently depending on what country you're in, and even within countries depending on what jurisdiction you're in. So within Canada, healthcare is actually a provincial and territorial responsibility. So it's not the government of Canada that tells clinicians how to assess capacity. It would be their provincial and territorial ministries of health that would do that if they're going to do it. So in some provinces, there are laws that lay out criteria for capacity. In others, like Quebec, where I am, there isn't a law that lays it out, but our regulator, the College of Physicians, so the equivalent of the GMC, I think, in the UK, says, these are the standards you need to adhere to when you assess capacity. So those include, does the person understand the nature of their condition, and do they understand what they're asking for? Do they understand the alternatives for relieving the problem that they're having, in addition to what they're asking for? Do they understand the risks and the benefits of what they're asking for? Can they reason about the information that they are being given? Can they apply it to their own situation? And can they evidence a choice? Can they actually make a decision? So there are many elements to what needs to be considered to say that somebody is capable or not. In healthcare settings, it would be pretty common practice that the rigor or the thoroughness, not of my assessment, but the extent to which a person needs to understand is going to vary depending what it is that you're proposing to them. So how well they need to understand the ins and outs of giving a blood sample is going to be different to how well they need to understand the ins and outs, like Our Lady who was being offered a lung transplant. So, but those would be the elements that clinicians would look at to establish whether a person has capacity. And I mean, if you're thinking, and I'm guessing from your face, that it's not black and white, you're right, it's not black and white. Some cases are very straightforward and some are much more complicated.
If you can wrestle your way through that capacity question, which is difficult, then you're going to end up with a group where actually, and I think you used the phrase rational suicide, there is no difference really between rational suicide and assisted dying. What you're trying to achieve is that the person has made a competent decision, and then the actual process by which they die, one would want it to be as good as possible, but it doesn't seem especially relevant necessarily which side it goes?
Well, I mean, there are certainly people that make their argument, and I'll turn to Edward here, who's the philosopher in the room. I believe the question of whether there is such a thing as a rational suicide is one that has received thousands of pages of treatment in philosophy. But I think there are certainly people who would say that. And I mean, if you follow the line of argument that I tried to develop here tonight, which is if a suicide is an intentional action to end one's life, then it can be rationally, that intention can be rational or not, and calling it suicide or calling it assisted death is kind of more of a social choice that we make because we want to demarcate certain groups from each other, or we want to demarcate certain practices, or we want to say this is okay and that's not okay, or we want to devote resources to certain things and not to others, right? So I think it's informed by these social choices rather than some empirical phenomenon of there are people out there who are suicidal and there are people out there who want an assisted death.
Thank you for this talk. You mentioned early on among the criteria for establishing, whether to even begin to contemplate this issue of suicide or assisted suicide. There was the notion of, I'm paraphrasing, intolerable, irreparable, kind of condition, incurable, sort of, and so on and so forth. And presumably that means a physical condition, not a mental condition. I mean, how do we distinguish the sort of the anguish of the body from the anguish of the mind? Is it just because we think we understand the functioning of the body better than we understand the functioning of the mind, we can say with greater certainty that, yes, this person is really, incurable, has an incurable illness of some sort, be it cancer or something else. Whereas if somebody doesn't demonstrate, let's say, any physical symptoms, but in their mind they believe they have an intolerable and incurable condition, how do we answer this question? Do you understand what I'm
I think I do. And there's actually a few questions in your question, so I'm going to try to parse them out as best I can. So the law actually doesn't say anything about whether somebody has this kind of condition or that kind of condition, whether you have to have a physical condition or a mental condition. And just as an interesting little fact, when Carter was decided in 2015, it gave the federal government 12 months. So it said, these bits of the criminal code that prevent assisted dying are against the charter, but we'll give you 12 months to decide if you want to legislate or not, and then in 12 months' time, this will take effect. And in the meantime, people who fall into this category that I've described, voluntary adults with a grievous and irremediable medical condition, can go to court. And they can say, based on this decision in Carter, I would like to receive an assisted death. And there were about 15 of those cases, and one of them was actually a person who had a mental disorder, a severe and chronic mental disorder. And the courts were really clear that the diagnosis was irrelevant, actually. The question was, did the person have a grievous and irremediable medical condition, regardless of what kind of medical condition it was? In the Truchon case that I showed you, she actually makes that, Justice Baudouin makes that very explicit and actually uses those words saying the person's medical diagnosis, their official diagnosis, is irrelevant. What matters is that 2 physicians have found they have a grievous and irremediable medical condition. So the kind of proper answer to your question is the law doesn't distinguish between them, and there's nothing in it that says that we should, we understand these conditions and therefore they're eligible and not those conditions. What happened was that because in the beginning Canada had an end-of-life requirement, de facto, people with mental disorders were not included because the overwhelming majority of them would not be at the end of life because of their mental disorder. Although, like case number 6, there might have been people with mental disorders who went through because they had something else. When that requirement was removed, then you have a greater potential for people with mental disorders to make requests, and some number of them to be considered to have a grievous and irremediable medical condition. So I would say that's one view in the medical profession, and I think the other view is that mental disorders are somehow fundamentally different, and that is why we need to exclude them, because we cannot establish their incurability. We cannot say that a person is in an irreversible state of decline. They may misunderstand their own suffering, and so they can never really fulfill the requirement, and it's safer to have an exclusion. So that debate is very much happening right now.
For fear of influencing people who have any sort of condition, are there any sanctions based on doctors recommending assisted dying unprompted to patients? Because there are a lot of factors. I mean, elderly people can feel pressured by their families. Those who can't afford healthcare can also feel pressure. And so suicide, whether assisted or not, seems to be reserved as a final resolution to these type of problems, that it is the last step. So in then recommending it to patients, you don't want to really be encouraging it, I guess.
Yeah, absolutely. There isn't a rule, certainly not in the law, that says anything about who is supposed to bring it up. Below the law, there are all kinds of other policy instruments that govern clinicians' behavior. So there are regulatory standards, there are the clinical guidelines produced by professional associations, there are the recommendations made by our malpractice insurers, and so on. And here you see some variation. So the insurer for the Canadian nurses, for example, told nurses, never bring it up. You're never allowed to bring it up, okay? On the physician side, and I remember this actually, there was sort of a rumor circulating that we were never supposed to bring it up, okay? But actually that was a rumor. It isn't said anywhere that we're supposed to bring it up or we're not supposed to bring it up. What I would say back to you is that here we need to rely on all of the rules and standards that exist in clinical practice, okay? Medical assistance in dying is not a completely separate entity that lives in a bubble over there. It's part of our healthcare system. So in the ordinary course of a clinical conversation, if an intervention was irrelevant, I would never bring it up. So what protects people from having it raised inappropriately by clinicians is that if it is irrelevant and inappropriate, it's inappropriate to bring it up. And if someone were to make a complaint, look, this doctor is suggesting it to my loved one or suggested it to me, that would be a sanctionable behavior. It turns out, though, that actually the example you gave is interesting. It turns out that the problem is the opposite. It's not that elderly people are being pressured to accept assistance in dying. It turns out that the problem is that elderly folks who live, say, in care homes, where there may be only one physician who's a consultant to that care home and who, as is entirely their right, does not participate in assisted dying or even has a conscious objection, doesn't bring it up. And so there are plenty of folks out there, it turns out, who would like to know about it anyway, even if they don't want to make a request, or make a request even if they're not eligible, who don't, because people don't bring it up, because they don't want to bring it up. So actually the reticence is more on the clinician's side to talk about it than it is on the patient's side having something pushed on them. For sure, there have been cases that have been presented in the media of people where it was proposed, although in I know of 2 cases. In one of them, it was not a healthcare professional at all. So it was clearly inappropriate that that person brought it up, and you'll be glad to know was subsequently fired. So I hope that answers your question.
Hi, first of all, thank you so much for your talk. It's very interesting. I'm wondering, in cases where someone is deemed psychologically insane and therefore they have a legal guardian that's making the choices for them, could that legal guardian request assisted death, or how do you deal with those cases?
Yeah, so we have slightly different terms. So we don't have the term psychologically insane, but we do have people who are considered to be incapable of making decisions for themselves and who have a guardian-like structure. But that was a very long preamble to say the answer is no. The legal requirements are that people themselves have to be capable and they have to consent all the way up until the moment of administration. There's a little exception about that we can talk about if you want, about people who are on the verge of losing capacity, but otherwise people have to make their own decisions and have to consent at the moment of administration. So there's no substitute decision making.
Thank you. I'm just curious what the kind of percentage is of people that do make this choice now that it is legal, and whether if suddenly it became a case of that, would there ever be a number of people that were making the decision that it became kind of alarming, or would people be neutral about it, like, if that makes sense? If it became kind of like a really common thing that people were doing?
Yeah, thanks for that. I feel like everybody here has secretly read everything that's going on in Canada, and you're just being very nice and planting all of these questions for me. So there has been a consistent growth year over year in the requests for assisted dying in Canada since 2016, and that trajectory continues. If we compare to other jurisdictions where the practice is permitted, like the Netherlands, for example, they've seen the same year-over-year growth, and then it plateaus at a certain point. So we're not at the plateau phase yet. And the national rate is somewhere around 4% of deaths, or between 3 and 4% of deaths. The latest data just came out actually in October, which is a little bit less than what it is in Europe right now. But nevertheless, yes, people are alarmed. And in fact, Quebec, which has an oversight commission where they look at all of the declarations that are sent in by the physicians who have helped someone to die, the head of that oversight commission actually made a fairly unprecedented public statement, because it's not really their role to comment on what's going on. They're there for oversight, to say that he was concerned that physicians no longer see assisted dying as the person pointed out, an intervention of last resort, and because he's alarmed that the numbers are going up, and the government of Quebec has just actually put together a scientific panel to look at it. I think for our purposes, the interesting question is, what is the right number of assisted deaths? Is it 5%? Is it 10%? If everybody said, when it's my time, I want an assisted death, is that bad?
Yeah, that's what I was thinking, because if this is the kind of thing that's being accepted, it then doesn't seem fair to put a cap on it in a way, because it's just, now this is kind of the view that we're all taking about it, if that makes sense.
Yeah, I mean, and there isn't a cap, but I think that the fact that the numbers are increasing and people are expressing concern about that without having expressed what the right number should be, I think reveals that we haven't thought about, I think, the moral question you're asking, which is a really good one. And yeah, I mean, that's something I think that every society needs to come to terms with, right? And if it is going up, what does that mean? And I think very legitimate questions can be raised about what's so terrible about dying, setting aside all of the obvious suffering bits, but what is bad about natural dying that makes people want this? And is that something that as a society we can do something about, right? Are people not getting good palliative care? Are people in institutions that are not hospitable, that make that time of their lives secure and comfortable? So, these are the questions I think that need to be answered.
Actually, a lot of what you were just talking about has something to do with what I wanted to ask. Is the reason for exclusion of mental health conditions from assisted dying primarily about it not meeting the end of life requirement, or is it also the acknowledgement that
a lot of mental health suffering is a consequence of political and social things. So my question being, is the reason for exclusion also that they see that it's an internal consequence of something that is externally driven, or is that understanding not quite in the legislature yet?
Yeah, thanks for that. And you've put that more beautifully than I think it is often expressed in the news in Canada. So just to be really clear, there is no longer an end-of-life requirement. So the exclusion has nothing to do with that. It is now possible for people with chronic, severe conditions to make requests, and people with mental disorders presumably could fall into that. So I think, yes, very much there is a part of the debate about mental disorders that concerns why do people have mental disorders, what is the nature of suffering from a mental disorder, does it have to do with things like structural vulnerability, systemic oppression, et cetera. And I think that is very much part of the conversation. And I think actually that argument is made most articulately by voices from the disability movement, for people talking about suffering related to disability and how much of this is a result from inadequate supports. Sure, we can talk about finances and money, but inadequate inclusion, systemic inclusion of disabled persons within society. So there is definitely part of that. And I think the response to it is the solution to that problem a blanket exclusion for all people, or is the solution to that problem to address that problem?
In terms of like I guess the ability to complete suicide, in some ways, does assisted dying not make that process easier? Because I feel like people are much less likely to, like in terms of completing suicide by yourself, it's very much the end of the line. But in terms of assisted dying, it kind of brings that line a little bit closer because someone else is helping you in a way, so it's harder to say no, I guess. Like even if you don't have to have quite the resolution if you were by yourself. Is that not the case?
I just want to make sure I understood the first thing you said. You said, is it easier, assisted dying?
I feel the assisted dying, you need to be less resolute than if you were to complete suicide by yourself. So it makes it, in a way, I guess, easier in terms of you don't have to be right at the end.
Yeah, that's a really interesting observation. And if you look at the United States, which is probably the best example, where I think now about 15 to 20 states have some kind of legislation allowing only assisted suicide. Okay, so there's no such thing as euthanasia or what we would call provider-administered assistance. The rates are quite a bit lower than they are in countries where there is provider administrators. So some people have pointed to that and made exactly the point that you've made. I think that this shows that when you actually have to do it yourself, you have to be very convinced. And perhaps all those other people in other countries like ours who are getting it, and they're getting it in a provider administrated way, maybe they would have changed their minds, for example, if they were required to do it themselves. So I think that question has certainly come up. Regime in Australia, for example, you have to administer it yourself, and you can only have provider assistance if you cannot physically do it yourself. So I think there have been different approaches to try to address exactly that issue. And the Swiss are absolutely intransigent. Under no circumstances is any physician administering anything to anyone. If you're going to do it, you're going to do it yourself, and that is their regime. So very much, I think, along the lines that you're saying. That said, it's really interesting, both in Canada and in the Benelux countries, that even though they all allow for both options, provider-administered and self-administered, the overwhelming majority of people who make requests want it to be provider administrated. So in Canada, for example, population is nearly 40 million. There were 13,000 assisted deaths last year. You could probably count on two hands the number that were self-administered. So what does that mean? This is a very good question. I don't know what it means. I think, based on sort of some qualitative research that's been going on in Canada, that People consider it to be more comforting to have the physician present, to know that if for whatever reason something didn't quite work, that person is there to manage the situation, that if they were to feel physically unwell or uncomfortable, that they would ensure that that was taken care of. So I think that's what people say, but I think the point about does it allow for some people who are not very sure to go forward? Maybe. People have to say they want to go forward even at the moment, but I think it raises the question.
Well, thank you for that wonderful presentation and also for the discussion we've been having. You mentioned at one point that some physicians might not feel able to participate in the decision-making process, and I found that very, very interesting. That was something I wanted to ask about. And I wonder if you could say, I think this is impossible to answer, but or at least succinctly, but I wondered what the response has been of clinicians, physicians, to how things are proceeding since the new legislation. I mean, obviously you've indicated numerous issues and the complexities of individual cases, but I wonder if you could say a little bit about that.
Yeah, sure. There's so many levels to address that question, right? There's what I'm going to talk about physicians here, just to keep it clear, because that's the kind of clinical population I know the best, or healthcare professional population I know the best. So there's kind of what people say in surveys. There's what people do when they have cases in front of them. And there's also what's happening over time. And I think that comes back to something that somebody raised over here about how things are shifting and how opinions are shifting. So when the laws came into effect, physicians, and just so that people are up to speed on this, typically physicians lag behind the population in support for assisted death. So if you look at opinion polls in countries that are considering it, you'll see that consistently physicians fall behind what the population wants. The population generally supports it, and then the physician support is lower. So at the time the laws came into effect, physician support seemed to be fairly high, maybe a little bit lagging behind the general population, but still fairly high. So in Quebec, for example, 3/4 of family physicians, of specialists, supported some assisted dying regime. What happens on the ground, though, is that now, after 7 years, less than 2% of the Canadian physician workforce participates in assisted dying, and that is quite a significant growth over the year before, even just 1 year before, and the years before that. So even though there was support for the idea, at the vanguard was really a very small number of people who believed in this practice and who wanted to make it available for patients who wanted it. The other interesting phenomenon is physicians who are willing to do it for a certain patient, for their own patient, for a patient that they knew really well, for a patient who talked to them about it many times over the years, but they're not going to do it for just anyone or for someone who they don't know. And I've also, in the course of a research project that I've been working on how physicians assess suffering in the context of MAID requests, heard the opposite, that there are physicians who are willing to do it for patients they don't know. So when they're called upon, they'll do it, but they will not do it for their own patients because it's too emotionally difficult. So now I think we're getting into, in this part of the answer, some of the details about how it's experienced by people. I think that particularly for the cases of requests that are not end-of-life requests, so since March of 2021, these are much more complex. There's much more medical and psychosocial information to wade through, often multiple visits with the individual, with their family members or people in their social network, meeting other clinicians, finding out about the evolution of their clinical condition. So for example, I was asked to be the second physician for a particular individual, and he had a psychiatric condition, but that wasn't why he was asking for an assisted death, because that's not allowed. So the condition that he actually has, I don't really know that well, so I had to spend quite a long time reviewing his medical file. I had to go and meet with his treating physician. I had to meet with his treating psychiatrist. I had to speak with his family. So many people don't want to do all of that, right? So that becomes another barrier. And some people will say, well, I'll do cases, what we call in Canada track 1, people who are at the end of life, but I don't want to do cases where people aren't at the end of life because it's just too much work. So I think really people support the idea. Not a lot of people want to do it. And there's a variety of reasons for that. And I would say that big majority of people, there are some conscientious objectors in there, but I think the vast majority of that group are not conscientious objectors. I think they simply don't want to get involved for personal reasons. It's too busy, it's not part of their clinical practice, they don't come into contact with patients at the end of life, et cetera.
Thank you for your talk, it was very interesting. I hope it's not presumptuous to say that suicidality is quite stigmatized, and suicide is a very stigmatized thing in society. That's, I assume, a big component of why people are so reticent to call assisted dying assisted suicide in many places. And this kind of follows on from the question about changing attitudes in Canada since the introduction of MAID. But do you think that it has further stigmatized or destigmatized the idea of suicidality and suicide in Canada?
Yeah, so the proper answer is I don't know. What I would say is that the way the question has been framed in Canada, what's the difference between these two, I think points to what you're saying, that if it's suicide, it's bad, and we should stop it. I think the stigma element is less associated with suicide per se in that debate and more associated with mental disorders, right? That a person with a mental disorder can't possibly make a rational request. And any indication that they want to die is suicidality, which is bad and needs to be stopped. So no, I don't think suicidality as such has been destigmatized. I think assisted dying is not as stigmatized as it was before it was allowed, obviously. And I think that's why, if you look at work that's done with people with lived experience, they think the exclusion is not a good thing. Not because they all want to have an assisted death, but because I think they recognize that this is in a continuum of intentional actions to end one's life. And they like the fact that over here, it's not so stigmatized, and psychiatrists don't chase after you, send the police to get you, and drag you into hospital when you talk about it. So, I mean, we have some early data on that from surveys of the People with Lived Experience Council from the Canadian Mental Health Association, of different studies that are being done now, small scale, people with lived experience. And I think, yeah, their interest in assisted dying is less about accessing assisted dying and very much along the lines of what you're saying, the ability to speak freely about wanting to end your life in a non-stigmatizing way.
Thank you very much for that. It was very interesting. I actually have two questions, if I may. The first is regarding capacity and capacity assessments. So I work within a neurology service, and we often have to repeat capacity assessments throughout a patient's stay. Often it comes about when, for example, it's discharging or things that feel that we don't agree with their decision, so capacity assessments occur. And just in terms of assisted dying, when capacity assessments are reassessed throughout that time. And the second is kind of an opinion in terms of what next. What do you think, if you were hypothetically able to make any decision you wanted to make, what do you think would be next in terms of this, like changing the vocabulary that we use or the definitions? Just be interested to hear.
So I just want to be sure I understood the first thing. Are you asking, is capacity reassessed?
Yeah, so is it something that's reassessed throughout someone's decision to go along the route of assisted dying, and when is that? So if they're deemed to have capacity and then lack it and then have it again, is that, or is it just on the like one occasion they're deemed to have capacity and then that's final?
Yeah, so good question. So I believe, like here, people are presumed to be capable. So there's a presumption of capacity. Nevertheless, in order for a physician to fill out a declaration that they have assessed and are going to provide an assisted death to someone, they have to document that the person has decision-making capacity, and so they have to assess it. And if there are reasons to think that it is unstable, so for example, the person has delirium, or that it's changing, they're losing capacity because they have cognitive impairment, then they would assess it on multiple occasions, if there's reasons to see that it's shifting. I would say that people who are requesters under track 2, so they are not at the end of life, it's more likely that they're going to have multiple assessments because they're being seen over a longer period of time. And oftentimes, and I believe like the amount of life shortening that is going on, because the overwhelming majority of Canadian MAID deaths are still for people at the end of life, even though it is allowed that you cannot be at the end of life. And oftentimes those folks are kind of dying imminently. So the capacity reassessment, there's less of a time frame for it to happen, and it's only going to happen if you think things are shifting quickly. Your second question, so what do I think should happen about the language? Oh, I would love it if we could all just say, it's all suicide, right? And let's just set about deciding when it's okay and when it's not okay, and actually have the real conversation, rather than having this like endless, tedious conversation. Well, how do we tell the difference? What tools do we need? What characteristics are involved? It's a dead end, I think, conceptually. And I think the little case studies that I showed you illustrate that. We already have a way of thinking about the times when we think this person's desire to end their life is not okay and we ought to stop it and do something about it, and over here it's okay. And I'd love to be able to just apply that same logic to this issue, because I think we would make more progress.
Can I, just following up on that remark, so I applaud your desire to not just consult what our intuitions are about the use of the word suicide and so on, but if in your words, we just had the real discussion, what in your view would be the criterion for distinguishing between when, let's call it suicide, was okay, and when assisted suicide is not okay? Would it be basically the slide you brought up about impulsivity and reasons and stability of state of mind? Is it that? Is that the touchstone for you, or is it something else?
Yeah, I think, if I could invent the eligibility criteria myself, I think I would borrow on a lot of these things. And the work that we've done in Canada trying to lay out a way of thinking or a path forward for assisted dying for persons with mental disorders very much draws on the things you're mentioning. So yes, the existing criteria, which I showed you at the beginning, but also, this should be stable, right? I'm actually putting aside for the moment, the characteristics of the person's condition. Let's forget about that for a minute. It should be stable, it should be non-impulsive, it should be well thought out, it should be consistent with people's values and beliefs over time. That's something that you can also find out from inquiring with their family or with the people who know them. So all of those aspects, which some people would argue go beyond the legal test of capacity. And that's okay if they do. Some people say no, capacity can cover all of that. Others say no, but even if it goes beyond it, there's no reason why that can't be folded in. And that actually, I think, would be appropriate for all kinds of requesters, not just people with mental disorders. And then as far as the condition goes, to come back, I think, to one of the very first questions, something that is very long-standing, that is very severe, that has not responded to multimodal, many different kinds of interventions. This is a way of thinking that we're already using in the rest of medicine for other kinds of requests that are non-mental disorder chronic diseases. So I think it would be the same kind of thinking. And fortunately, that scenario is rare, but it does occur.
Thank you. And if I follow up that, has there ever been a case in Canada, or let's say, where somebody has wanted to pursue the assisted suicide route, has had a mental disorder, but where suicidality is not a diagnostic criterion for that disorder? So I don't know whether there is any mental disorder that's sufficiently, that would pass the severity and irreversibility criterion, but where suicidality is not a diagnostic criterion. But it seems to me that if there is such a thing, it's peculiarly unfair to exclude mental disorders from consideration for assisted suicide just because they're mental.
Mm-hmm, mm-hmm. Well, absolutely. Schizophrenia is a very good and well-known example, right? Suicidality is not part of the diagnostic criteria for schizophrenia. So nevertheless, folks are excluded because currently there's a blanket exclusion.
I was just wondering, in situations where somebody develops a mental health disorder after a diagnosis, how do you tackle those situations? So let's say somebody has a cancer diagnosis and then becomes severely depressed after the diagnosis and wants to have an assisted death. How do you tackle those situations where the mental health disorder comes after?
Are you asking how do you tackle it from a legal point of view because of the exclusion, or how do you handle it clinically?
Clinically.
Okay. I'm going to invite myself to answer the legal question anyway, because it's relevant to the clinical question. And the answer is that case that you just gave, I think, illustrates the absurdity of the exclusion clause. Because, in fact, all kinds of people with medical conditions who might also have a psychiatric condition can still make requests and be considered to be eligible. So, like, what magic are we doing with them that we can't do with somebody who doesn't have the physical condition at the same time? I mean, as a psychiatrist, I would say none, right? So, but in the specific example that you gave, so the person makes a request, and then we think there's some psychiatric condition that's either emergent or has been reactivated and is at play. I mean, you would apply the eligibility criteria, and if you think that the person's decision is not capable, because the psychiatric condition is interfering with it, then they wouldn't be eligible. Yeah. I'll just throw out there that I thought this was a good idea, actually, that in the cases of people who make requests who are not at the end of life, the government added some different safeguards, and one of them is that the person has to give serious consideration to all of the alternatives that they might have. And since capacity is talked about somewhere else in the law, the group that Edward mentioned that I participated in that was making recommendations to the government said, well, this is clearly not about capacity because capacity is somewhere else. Serious consideration must mean something else. And we took advantage of that to recommend that serious consideration be consideration that's not impulsive, that's stable, that's well reflected, et cetera. So to try to bring in those ways of thinking about decision making that might go beyond legal capacity, and I think would very much apply to that kind of case. So even if sort of on strictly legal terms she understands, appreciates, and can reason, if nevertheless the decision is motivated by depressive cognitions, I'm a terrible person, the world would be better off without me, then we'd say, well, you know, she can't give serious consideration and she wouldn't be eligible at this time.
I was just wondering, because you mentioned about kind of discussing with family members or people around them as well. I was just wondering how much weight is put on that. Like if the individual had made the decision, but you spoke to their family or the people around them and they were really against them doing it, would this have any kind of, would you do anything differently, or does ultimately that not make a difference in the decision?
Yeah, so again, there's a legal answer and there's a clinical answer. And I just want to kind of first say that it's really important to remember that as a society, Canada made a decision that assisted dying is going to happen in a healthcare context. So that means all the usual rules, norms, standards, guidelines of clinical practice apply to assisted dying as well. So getting a family involved in a big decision is just good clinical care. That's what we do for anybody, anytime, when we can. There are people that don't want their families involved, and capable people who don't want their families involved are entitled to not have their families involved. So we're not allowed to go and involve family if the person says, legally, I don't want my family involved. Of course, the good clinical thing to do at that point is to say, why don't you want your family involved? And to try to find out more about that and see if there's something reparative that can be done. Now let's go in the other direction. The family who is involved and who says, no, absolutely not, I don't want my loved one to have an assisted death. No, that carries no weight, actually. It creates all sorts of family chaos, which, again, at a clinical level, we have to sort out. But from a legal point of view, no, a family member cannot veto a competent person's request. And there was actually, in fact, jurisprudence on this because a wife tried to stop her husband from having an assisted death, and the court was absolutely clear that she could not do so if he was capable to make his own decision.
Thank you very much. And that conveniently brings us to time. So thank you so much for the talk, and thank you all very much for your participation.
I just add my thanks to Edwards. It was really a great pleasure to have the opportunity to discuss with you, and I was so impressed by the level of the exchange. So thank you again for a wonderful evening.